Welcome to this high-yield MSRA Masterclass Explainer. If you're prepping for your exams, you already know that haemoptysis is one of those classic presentations that can literally point to dozens of different pathologies. Today, we're going to rapidly break down the pathophysiological sources and the exact diagnostic clues for haemoptysis to get you completely exam ready. Oh, and by the way, did you know coughing up just 100 milliliters of blood is considered a medical emergency? Let's conquer this topic together.
Here's our roadmap for today. We'll be looking at the anatomy of the bleed, cancer and infection causes, cardiovascular and autoimmune triggers, some high-yield mnemonics, and we'll wrap it all up with MSRA practice questions.
All right, part 1, anatomy of the bleed.
So the absolutely crucial point here is that true haemoptysis originates specifically from the subglottic respiratory tract. This single anatomical distinction helps us immediately rule out upper airway bleeds, like say a severe nosebleed draining backwards, or gastrointestinal bleeds like haemoptysis. Basically, if it's haemoptysis, it is coming from below the vocal cords.
Now, you might naturally think the pulmonary circulation is the main culprit, right? But incredibly, 90% of massive haemoptysis originates from the bronchial circulation. These are high-pressure systemic arteries that supply the airways. Because they're under systemic pressure, they are incredibly prone to severe bleeding when they're eroded by chronic inflammation, bronchiectasis, or a growing malignancy. The pulmonary circulation, which is a low-pressure system, only accounts for the remaining 10% of cases, stuff you typically see in conditions like a pulmonary embolism.
Moving on to part 2, cancer and infection causes.
If a clinical vignette mentions an older patient with a heavy smoking history, finger clubbing, and B symptoms like weight loss, you are immediately thinking bronchogenic carcinoma. For tuberculosis, the exam will almost always give you chronic low-grade fevers, drenching night sweats, and upper lobe fibrocavitary disease. But the really massive high-yield clues lie in these next two conditions. For bronchiectasis, the defining narrative is a long-standing history of coughing up copious amounts of purulent sputum paired with tram track opacities or ring shadows on imaging. And for an aspergilloma, a fungal ball, you're looking for a classic crescent sign. This is a rounded opacity sitting inside a pre-existing cavity, usually a legacy TB cavity, surrounded by a crescent of air. Spotting that crescent sign is an instant point on the exam.
Let's pivot to part 3, cardiovascular and autoimmune causes.
For cardiovascular causes, try to picture the clinical presentation in your mind. A patient presenting with acute pleuritic chest pain, unexplained fast breathing, and risk factors for a venous thromboembolism? Well, they have a pulmonary embolism until proven otherwise. On the flip side, if a patient is coughing up pink, frothy sputum, struggling to breathe when lying flat, and you hear an S3 gallop on auscultation, that is your classic exam giveaway for pulmonary edema secondary to left heart failure. Elevated hydrostatic pressure is literally forcing fluid and red blood cells right into the alveoli. Finally, look out for mitral stenosis. The key narrative here is a long-standing history of rheumatic fever. If they mention a malar flush, an unshifted apex beat, a loud S1, or a low-pitched mid-diastolic murmur best heard at the apex, lock in mitral stenosis.
Okay, let's tackle the autoimmune categories, specifically the pulmonary renal syndromes. I like to call them the GN duo, because they both cause glomerulonephritis and pulmonary hemorrhage. But how do you actually tell them apart when the pressure is on? First, consider granulomatosis with polyangiitis, or GPA. GPA famously attacks the upper airway as well as the lungs and kidneys. Look for clues like a saddle nose deformity, epistaxis, or nasal crusting. If the upper airway is involved, it's GPA, and it's going to be C-ANCA positive. Now, contrast that with Goodpasture syndrome. It also causes acute pulmonary hemorrhage and rapidly progressive glomerulonephritis, but it crucially spares the upper respiratory tract. No saddle nose, no epistaxis. Plus, it's defined by anti-GBM antibodies, which target type 4 collagen in the basement membranes. So remember, upper airway involvement is your absolute key discriminator here.
Part 4, high-yield mnemonics.
If you remember one thing today, make it these cheat codes. For the GN duo, Goodpastures means anti-GBM with kidney and lung involvement only. Wegener's, or GPA, means C-ANCA with kidney, lung, and upper airway involvement, often flagged by a saddle nose. And when a question describes massive, catastrophic haemoptysis, your brain should immediately jump to the big three: bronchiectasis, aspergilloma, and bronchogenic carcinoma. Knowing these exact contrasts and primary culprits will practically answer the questions for you.
Part 5, MSRA practice questions.
Welcome to the lightning round. Follow along and see if you can anticipate the answer before I explain it. Imagine a 45-year-old female presents with recurrent haemoptysis, breathlessness, and an irregular pulse. Auscultation reveals a loud S1 followed by a low-pitched mid-diastolic murmur at the apex. What's the underlying valvular pathology? Well, notice how the loud S1 and low-pitched mid-diastolic murmur immediately anchor our diagnosis to mitral stenosis. That irregular pulse is likely atrial fibrillation, which is a common complication of the stretched left atrium in this condition.
Next scenario. A patient with a history of treated pulmonary tuberculosis presents with haemoptysis. A chest X-ray shows a mobile, rounded mass within an upper lobe cavity outlined by a crescent of air. What is this lesion called? That combination of a legacy TB cavity and a crescent of air is your neon sign for an aspergilloma, or fungal ball. The mass is literally moving inside the old cavity, which is exactly why they describe it as mobile.
A patient presents with epistaxis, a saddle nose deformity, haemoptysis, and rapidly progressive renal failure with red cell casts in the urine. Which specific autoantibody is diagnostic? Okay, that saddle nose deformity and epistaxis confirms upper airway involvement. Because the kidneys and lungs are also failing, this seamlessly leads us to granulomatosis with polyangiitis. And the diagnostic marker for GPA? The C-ANCA autoantibody.
A patient presents with simultaneous pulmonary hemorrhage and glomerulonephritis, but has no upper respiratory tract symptoms or nasal crusting. Serology tests positive for anti-glomerular basement membrane antibodies. What is the diagnosis? Here we see the contrasting presentation to our last question. The absolute lack of upper airway symptoms, no nasal crusting, no saddle nose, paired directly with positive anti-GBM antibodies, strictly defines Goodpasture syndrome.
A 60-year-old man presents with a multi-year history of a chronic cough productive of large volumes of purulent sputum daily, recurrent chest infections, and digital clubbing. What's the most likely diagnosis? The timeline is key here. A multi-year history of copious, large volumes of purulent sputum perfectly describes the chronic, permanent airway dilation and poor mucus clearance of bronchiectasis. The recurrent infections are what eventually erode those high-pressure bronchial arteries, causing the bleed.
In cases of massive, life-threatening haemoptysis, from which high-pressure arterial system does the vast majority of bleeding originate? Recalling our earlier statistics, remember that 90% of massive, life-threatening bleeds stem from the high-pressure bronchial circulation. Because it operates at systemic arterial pressure, an erosion here is a massive medical emergency.
An elderly patient with acute shortness of breath in an S3 gallop rhythm coughs up pink, frothy sputum. What is the underlying physiological mechanism here? When you see pink, frothy sputum alongside an S3 gallop, you must immediately connect this to left heart failure. The failing left ventricle causes fluid to back up, increasing hydrostatic pressure until the alveolar capillaries literally rupture, resulting in acute pulmonary edema. A patient presents with acute onset pleuritic chest pain, dyspnea, mild haemoptysis, and tachycardia following a long-haul flight. What investigation is first line if they're hemodynamically stable? The context of a long-haul flight heavily suggests a venous thromboembolism risk. Paired with acute pleuritic pain and tachycardia, you are highly suspecting a pulmonary embolism. Therefore, the first-line definitive investigation for a stable patient is a CTPA, often guided first by a Wells score. What specific structural nasal deformity resulting from cartilage destruction is classic for granulomatosis with polyangiitis? This is a classic visual buzzword. The severe inflammation and cartilage destruction in GPA creates the definitive sunken-in appearance known as the saddle-shaped nose deformity.
A young immigrant presents with a chronic productive cough, streaking haemoptysis, low-grade afternoon fevers, drenching night sweats, and significant weight loss over 3 months. What is the initial diagnostic test? Finally, those drenching night sweats, low-grade fevers, and constitutional symptoms scream tuberculosis. To confirm this, your essential first steps are a chest X-ray to look for upper lobe cavitations and a sputum culture looking for acid-fast bacilli.
I really hope this explainer has sharpened your diagnostic reflexes. But before we go, think about this. If a patient walks in with a fever, a cough, and haemoptysis, which classic triad of symptoms will you actually rely on to tell the difference between a simple infection and a full-blown autoimmune crisis? Keep that question in the back of your mind as you hit the words. Keep studying smart, and I'll see you in the next explainer.